Welcome back to the deep dive. Today, we are undertaking a massive mission.
I'd say so.
We're providing a high-speed, clinically focused summary of Z.M. Seagal's 2018 Topographical and Pathotopographical Medical Atlas. It's basically an essential map for navigating the human body, from the chest all the way down to the retroperitoneum.
And this isn't, just some dry list of bones and muscles. This atlas gives you everything layered: anatomy, variants, CT, and MRI topography.
It's the real deal.
It really is. It's the ultimate shortcut for medical students, for residents, for anyone who needs to translate a precise coordinate into a high-stakes clinical action. Our goal here is to filter all this incredibly dense data into memorable conversational nuggets that explain why these details matter so much.
We've laid out our surgical map. We'll start with the boundaries of the chest, move on to the complex layering of the abdomen and hernia mechanics, of course.
Can't skip hernias.
And then we'll dive into the hidden anatomy of the lumbar and retroperitoneal spaces, which is often, I think, the most challenging region for a lot of people. So let's grab our proverbial scalpel and begin with the thorax.
Okay, when we talk about the topographical anatomy of the chest, we have to start with the borders. I mean, those lines dictate where a surgeon can even begin to think about safely accessing the cavity. So what are the non-negotiable superior and inferior borders?
So the chest, or the thorax, is defined really clearly by its bony landmarks.
Okay, the framework.
Exactly, the superior border. You can think of it as a line connecting the upper edge of your clavicle, the manubrium of the sternum, and then running all the way back to the spinous process of C7.
The seventh cervical vertebra. Got it.
And inferiorly, the border kind of sweeps obliquely. It goes from the xiphoid process, follows those costal arches, and then ends at the T12 spinous process in the back.
So C7 and T12 really are the extremes of that thoracic cage, front to back. And the walls themselves, we're talking about some massive muscle groups here, right? Oh, huge. You have to acknowledge the primary muscular layers providing structure. You've got the latissimus dorsi posteriorly, the serratus anterior on the sides.
And the pecs up front.
And the pectoralis major and minor anteriorly, yes. Understanding the fiber direction and layers of these is just key to preventing complications during access. Now let's look at the projections of the pleura and the lungs. This is a classic surgical trip hazard.
Oh, I can imagine.
The lower margins of the pleura, that protective membrane, they dip significantly lower than the actual lung tissue. They follow the 7th rib at the mid-clavicular line, the 10th rib at the mid-axillary line, and go all the way down to the T12 vertebra.
Wait a second. If the pleura goes down to the 12th rib, but the lung tissue doesn't that create a really specific window of risk for procedures?
It absolutely does. It means if you're doing, say, a kidney biopsy or trying to access the upper abdomen and you mistake that pleural margin,
you could cause a pneumothorax.
A catastrophic pneumothorax. And also, you have to remember the apex of the cervical pleura. It actually rises 2 to 3 centimeters above the collarbone anteriorly. It's this tiny, exposed vulnerability.
That structural insight is the whole point of this deep dive. Okay, let's move to the most critical projection in the chest, the heart and the great vessels. Where do they live in relation to the sternum and ribs?
Well, the atlas gives us surgical precision here. The heart's upper margin sits right at the 3rd costal cartilage. Its apex is projected at the 5th intercostal space on the left.
But not all the way out.
Right. It stops about 1.5 centimeters shy of the midclavicular line. As for the major highways, the ascending aorta starts behind the sternum at that 3rd intercostal space and then arcs into the aortic arch at the 2nd right sternocostal joint.
That 2nd right sternocostal joint. That detail is critical. If you're talking about central line placement or trauma, that's a zero tolerance zone for error.
Precisely. And right nearby, the superior vena cava is formed a little higher up at the 1st costal cartilage. It then empties into the right atrium at the 3rd costal cartilage.
Yeah. And the esophagus.
The esophagus runs from C6 down to T11, and it has this distinct topographical curve. It starts to the right of the midline, crosses left around T2 to T4, and then crosses left again to exit through the diaphragm at T10.
Let's talk about that foundation of the chest, the ceiling of the abdomen, the diaphragm. This muscle is just full of clinically relevant holes.
It really is. The diaphragm is unique. It's muscular, sternal, costal, and lumbar parts. But it also has this major central tendon, the centrum tendineum.
And the heart sits right on it.
The heart sits directly on the anterior section of this tendon. And knowing the 3 main openings or apertures is just vital for managing trauma or, say, hiatus hernias. You have the aortic hiatus located posteriorly at T12, which lets the aorta and the thoracic duct pass through.
Okay.
Then there's the esophageal hiatus, a bit higher up in the muscular part, which transmits the esophagus and the vagus nerve. And finally, you have the IVC foramen, which is fixed within that tough central tendon, transmitting the inferior vena cava.
And the atlas also highlights 2 weak points on the diaphragm, which seem really vulnerable to pus or infection breaking through. Can you define those for us?
Yes, these 2 weak spots are crucial for understanding how abscesses and hernias travel. First is the lumbocostal triangle, located between the lumbar and costal parts.
Right.
This area is only covered by thin pleura and fascia, and it's right next to the kidneys and adrenal glands. So it's a potential site for deep retroperitoneal abscesses to break through into the chest.
And the second one?
The second is the sternocostal triangle, located more anteriorly, right behind the sternum.
Before we move down, let's just briefly touch on the mammary gland. Given how often it's involved in pathology, what key anatomical structures does the atlas really emphasize?
Structurally, you're looking at 15 to 20 lobes. For any surgical intervention, though, the key takeaway is its really robust tripartite blood supply. The internal thoracic artery, the lateral thoracic artery, and the intercostal arteries.
In the lymphatics.
But most critically, yes, lymphatic drainage. That's what determines cancer spread. The primary highway is the axillary lymphatic outflow pathway. Knowing this pathway dictates the entire extent of any surgical resection or biopsy.
That's a perfect segue. The precision needed in the thorax is intense. Now, let's move south and shift our focus to the abdomen, where the layering of the anterior wall holds the key to understanding a really common surgical problem: hernias.
When you're mapping the anterior wall, we still rely on the 9 classical regions, epigastrium, hypochondriaca, umbilicalis.
The old school map.
It works because it allows for instant clinical projection. If a patient has pain in the hypochondriaca sinistra, you immediately think spleen, tail of the pancreas, part of the stomach.
The layering is so vital here, especially with the rectus abdominis sheath. Why is the anatomy below the semicircular line so important for surgeons to know?
Because it's the Achilles heel of the anterior abdomen.
Okay.
Above that line, the aponeuroses of the muscles contribute really robustly to both the anterior and posterior sheaths. But below that line,
It changes completely.
the posterior wall is fundamentally missing. It's only covered by the thin transverse fascia and the peritoneum.
So surgically, an incision below that line faces a much weaker wall. That's a much higher risk for wound dehiscence or an incisional hernia.
Exactly. It's a key zone of vulnerability. And we should also mention the superficial vascular networks in the superficial fascia. When flow is blocked, say, from portal hypertension, these veins just expand dramatically.
The ones that cause the classic caput medusae sign around the umbilicus.
That's the one. The portocaval anastomoses, using the perumbilical veins, connect the umbilical circulation directly to the portal vein system. Their expansion is that telltale sign of blocked portal flow.
And there's another set.
Right, the cavo-caval anastomoses, like the thoracoepigastric veins, which bypass the liver entirely and connect the SVC to the IVC system via the femoral veins.
Let's pivot to hernias. The atlas distinguishes between direct, slanting, and femoral types, based purely on anatomical preconditions. What are the key distinctions?
Okay, so inguinal hernias are all about their exit point. The direct inguinal hernia, common in the elderly, thrusts straight out through the fossa inguinalis medialis.
And that's due to weakness.
It's caused by general tissue atrophy. Conversely, the slanting, or external oblique, hernia is often congenital. It's from the failure of the processus vaginalis to close. It's basically a preformed sac exiting lateral to the cord structures.
And then you have the femoral hernia.
Right, which forms at the femoral ring. And this is where anatomy explains patient demographics. The ring size is significantly larger in women, about 1.8 centimeters, than in men, where it's 1.2 centimeters.
And that explains everything.
That size differential is exactly why femoral hernias are overwhelmingly more common in women. The anatomical opening is just inherently wider and weaker.
That's a fantastic clinical application.
Yeah.
Okay, let's move inside the cavity now. How does the atlas organize the organs within the peritoneum?
Well, organs are classified by their relationship to the peritoneum. Intra, mezzo, or extraperitoneal. But the organization into the 4 main bursae, or spaces, is crucial for understanding how infection spreads.
The four bursas.
You have the right and left hepatic, the pregastric, and the omental bursa, sometimes called the stuffing box, the ducta, which is a complex space behind the stomach.
And clinically, what's the most important takeaway there?
Clinically, you have to highlight the difference between the lateral channels. The left lateral channel is open. It connects freely to the small pelvis, making it a critical pathway for pus or blood to distribute throughout the entire cavity.
And we have to talk about the surgical highway that runs along the lesser omentum, the ligamentum hepatoduodenale. Why is this the most high-stakes piece of tissue in the upper abdomen?
Because it carries the anatomical triad that controls the liver. You've got the common bile duct, the portal vein, and the hepatic artery. All three.
All in one bundle.
Exactly. Any surgical intervention or trauma there requires immediate control of all three major structures.
Let's look at the stomach and duodenum. Their vascular system forms a key protective arch.
Right, so the stomach has its functional zones and specific nerve supply from the vagus nerve. The anterior nerve of Latar's, in particular, is a critical branch to the pylorus. Then the duodenum, mostly fixed retroperitoneally, wraps around the head of the pancreas.
And that arch.
The vital safety net here is the pancreaticoduodenal arterial arch. This arch is formed by the anastomosis between branches from the celiac system and the superior mesenteric artery system. It ensures a robust, redundant blood supply, which is a crucial consideration during resections.
Next up, the liver, gallbladder, and the non-negotiable surgical landmark, the Kalat triangle.
So the liver's lower surface, its syntype, is defined by the 6 organs next to it: colon, right kidney, adrenal gland, stomach, esophagus, and duodenum.
But for surgery,
But for gallbladder surgery, a cholecystectomy, the Kalat triangle is everything. Its borders are the cystic duct, the common hepatic duct, and the cystic artery. Identifying and securing that cystic artery within this triangle is step 1 of the procedure.
okay, and before we move on, what's the key takeaway on the portal vein system?
The portal vein is formed behind the pancreas head by the junction of the superior mesenteric vein and the splenic vein. Knowing its major inflows is just key to understanding venous pressure and the risk of hemorrhage.
Now we delve into the deepest core, the lumbar and retroperitoneal areas, really the hidden anatomy. What are the 2 structural weak points in the posterior abdominal wall?
These 2 areas are critical for understanding how infection or hernia is present on the back. First, you have the triangle of Keat, which is bounded by the external oblique, the latissimus dorsi, and the iliac crest.
A common pathway for abscesses.
A common small pathway, yes. But the second, larger, deeper weakness is the quadrangle of Lisgaft-Grunfeld. It's bounded by the serratus posterior inferior, the internal oblique, the erector spinae, and the 12th rib. If a deep infection forms in the retroperitoneum, this is often where it finds a path to break out.
The anatomy of the retroperitoneal space is really all about its fascial compartments, especially the ones that encase the kidney.
This is containment anatomy in action. The kidneys are surrounded by this thick protective layer of fat, the renal adipose capsule.
Okay.
And enclosing that whole unit is the renal fascia, which is split into the fascia prerenalis anteriorly and the fascia retrorenalis posteriorly. Crucially, these 2 sheets fuse and seal themselves off, both superiorly and inferiorly, forming a closed fascial bag.
So that's what contains an infection.
That is the anatomical mechanism that limits the spread of infection or hemorrhage, keeping it mostly confined to that perinephric space. And we should note, the kidneys sit quite high from T11-112 to L2. Remember the order in the hilum: vein, artery, pelvis, anterior to posterior.
Yeah, and the vessels have that asymmetry.
A very distinct vascular lateralization. The right renal artery is longer and passes behind the IVC, while the left renal vein is longer and passes in front of the aorta.
We also need to touch on the congenital abnormalities documented in this region.
Right. You see several variations. Things like renal dystopias, where the kidney is displaced down in the iliac fossa or pelvis. The type is defined by where its renal artery originates.
A useful diagnostic marker.
Exactly. Another common one is the horseshoe kidney, where the lower poles are joined. And finally, ureter strictures, or narrowings, which most often happen where the ureter joins the bladder. That leads to that dangerous backup of fluid hydronephrosis.
Let's transition now to the pathotopography, the clinical application of all this detail when things actually go wrong.
Let's start with the mammary gland and fibroadenoma. This benign tumor is often classified as immature. So juvenile, no capsule, or mature, with an external envelope.
And the mature one needs surgery.
The mature form won't regress without surgery, correct. But the crucial diagnostic differentiator from cancer is mobility. A fibroadenoma can be easily moved within the tissue, whereas cancer tends to be fixed or adherent.
And what about the peripheral form of lung cancer? Its location seems to dictate its lack of clinical presentation.
Precisely. Because it starts in the periphery, it's often asymptomatic for a long, long time, which delays diagnosis. The classic radiographic sign the atlas highlights is the nodule with an umbilication symptom.
Umbilicate.
It describes how a tendon or fascial structure is visibly pulled into the node, confirming its malignant nature on an image. You know, post-pulmonectomy anatomy gives us a great insight into mediastinal mobility. When a lung is removed, the chest cavity volume has to be compensated for.
So everything shifts.
Everything shifts. The biggest change is the diaphragm rising, sometimes dramatically high, up to the second rib. And the lower and upper parts of the mediastinum are highly mobile, so they shift over, displacing the heart, the great vessels, and the esophagus to fill that empty space.
What about the clinical dangers associated with liver hemangiomas?
Well, you distinguish between capillary, which are small, multiple vessels, and cavernous, which are these large, thin-walled cavities, sometimes up to 20 centimeters.
And those are the dangerous ones.
The clinical danger is almost exclusively with the cavernous type. Because their walls are so thin, they have a high probability of rupture, which results in acute hemoperitoneum, a massive bleed.
An emergency. Let's finish by circling back to spleen and gallbladder variations.
For the spleen, surgeons must always look for an accessory lobe or an accessory spleen. It's usually near the hilum. If a patient is having a splenectomy for a disease like ITP, that accessory spleen must be removed or the disease is very likely to come back.
A technical point that's easily missed.
Very easily missed. And for the gallbladder, congenital deformations like S-shaped kinks you see in children disrupt bile passage. That leads to bile stasis, dyskinesia, and eventually cholecystitis.
This deep dive really confirms that mastering topographical anatomy is, in essence, mastering the language of surgery. Understanding where fascia limits spread, where vessels intertwine, where the natural weak points lie, that's the core of predictive, proactive clinical practice.
Absolutely. The Siegel Atlas is a testament to the fact that anatomical knowledge is the difference between reaction and precision. Knowing the normal is the only way you can quickly recognize the pathological when the clock is ticking.
To leave you with a final thought and a chance to apply this knowledge immediately, we talked about the critical fascial sheets that enclose the kidney in the retroperitoneal space. So if a large abscess were to form within the capsule adiposa rennis, the adipose capsule surrounding the kidney, what two key fascial sheets would primarily limit the vertical spread of that infection, both superiorly and inferiorly?
Think back to how those anterior and posterior fascial layers behave once they pass the kidney itself.
We encourage you to review the discussion of the renal fascia in Part 4. Until our next deep dive, keep digging into the details that matter.